Hello, my name is Laura Lazzarini, and I'm one of the Pediatric Pulmonary Fellows at Children's Hospital Los Angeles, and I'll be presenting Can Families Safely Care for Their Ventilator-Dependent Child at Home? And a little bit of background, at CHLA, we care for an average of 200 home mechanical ventilation or HMV patients per year. HMV patients do have an increased mortality rate of 20 to 27% or so, and there is also increased risk of hospitalization for this patient population as well. And while we were able to safely discharge patients home, train families to care for their ventilator dependent children at home, we did not necessarily have an established multidisciplinary action plan of how to do that training for those families. And so a wonderful group of people at CHLA started a pilot multidisciplinary action plan, or MAP as we refer to it, in July of 2013. It was a multidisciplinary team, and the goal was to assess patient outcomes and caregiver satisfaction after the initiation of this pilot HMB MAP training program. So the concept behind this pilot study is, there's so many different disciplines that are involved in the care for a patient and their family, especially for the HMB pediatric patient population, from the physician to the social support with the social worker, child care, spiritual care, the therapists, the bedside providers like the RNs and RTs, dietitians, care coordinators. There's so many different people involved, and we're all working together as a team, with the focus and center of that teamwork being the patient and their family. So once a multidisciplinary committee was established, they created a seven-phase map to train families on how to care for their ventilator-dependent child at home. Each discipline came up with a variety of tasks that needed to be completed to complete the HMB MAP training program, and they established an estimated length of stay that would be required of 6 to 7 weeks. They then went to the staff on a respiratory care unit to teach them about the MAP to ensure that there would be adherence to the MAP for the patients that were undergoing this pilot study. Did daily reviews of how patients were doing, and made adjustments as necessary. And they looked at the outcomes of length of stay, readmission rates, emergency room visits, and caregiver satisfaction. A little bit more about our MAP. Unfortunately, not every child that is ventilator dependent will be an HMB MAP candidate. The patient needs to have two identified caregivers willing to undergo the HMB MAP training. They need to pass a home inspection that ensures there's adequate space and electricity for the child to be cared for safely at home. Once HMV candidacy is established, we proceed with a family meeting, and the participants at that meeting include the primary caregivers, the primary pulmonologist, the social worker, the nurse care manager that the family will be working with extensively as an outpatient, and the clinical care coordinator who helps order the medical equipment necessary for the child, the patient care nurse, and the RT ideally as well. And the topics that we cover include mortality. We want families to understand the risks associated with the decision to proceed with home mechanical ventilation and ensure that they're ready to take on the challenge of this training program and make the most use of it to ensure they can care for their child safely at home. We review home nursing, the training itself, discharge criteria, and the equipment and supplies that will be necessary. This is an example of the checklist that needs to be completed by each caregiver prior to discharge. You can see that there is a variety of things needed to be covered, including tracheostomy training, multiple ventilator classes, G-tube classes if applicable, medication education. There's a home emergency class that is done, where multiple scenarios are provided to the families in case there were some tracheostomy or ventilator malfunctions, so they can be as best prepared as possible. And each caregiver will demonstrate 24 hours of independent care in the hospital setting, to ensure that they're comfortable and able to care for their child safely at home prior to discharge. And we're fortunate to have cared for a large population of home mechanical vent pediatric patients, so that prior to the pilot, we were able to get some baseline data. Um, Patients that were HMV dependent, between 2003 and 2009 were studies. There were a total of 109 patients studied. And the review of that patient population showed that 46% of those patients were readmitted within 30 days for respiratory complication, and 31% were readmitted within 30 days for non-respiratory complications. Now, fast forward to the HMV MAP pilot study. There were 38 patients studied between 2013 and 2016, and after the initiation and completion of the HMV MAP by the caregivers of said patients, Only 7.9% of patients were readmitted within 30 days for respiratory complications, and 10.5% were readmitted within 30 days for non-respiratory complication. And so with that positive outcome of reduced readmission rates with the initiation of this H&V map over a 6 to 7 week timeline, there was some thought, can we make this process more efficient, but still keep it safe for the families and have similar outcomes with a 4 week map? The timeline of the map was refined. And again, we set that new goal of 4 weeks. And part of the decision behind that was reviewing the length of stay of patients in the 6 to 7 week map. You can see there was a variety of length of stays, but the majority of patients were able to discharge within 4 to 7 weeks. And that's where I come in. So I'm working on a retrospective descriptive study that's IRB approved. The inclusion criteria and exclusion criteria are listed below. The outcomes that we're following are emergency department presentation within 48 hours of discharge and readmission within 30 days of discharge, similar to the pilot study as well. Some prelim data focusing on the characteristics. We have 40 patients we've been able to study thus far. The majority of those patients that we're studying that are H&V dependent are infants. So most of them are 0 to 1 year old, but you can see we have a variety of patients across multiple age groups. 70% of the patients are male, and the majority of the patients require ventilator support due to increased respiratory load, but we also have patients that require the ventilator for ventilatory muscle weakness and central hypoventilation. And so we set this goal of 4 weeks, a 4 week map. How did we do in terms of length of stay? Well, of the 40 patients that we've studied, you can see again, similar to the pilot study, there are a variety of length of stays, but the majority of patients are able to discharge within 3 to 6 weeks. You can see that there were a number of patients that had length of stays greater than 8 weeks. And I think that this just speaks to the fact that a lot of these H&V patients are quite complicated. And there are other things going on while families are undergoing this H&V training, such as sedation weans that might not be tolerated, feeding intolerance. There can be respiratory infections that come up. So this just speaks to the fact that, there are multiple aspects of the patient's care in addition to the H&V map training that's all happening at the same time. And then looking at the outcomes, we were able to see that with the 4 week map, the readmission, the percent of patients readmitted within 30 days for respiratory associated complications was similar, but slightly up at 12.5% compared to 7.9% of the 6 to 7 week map. The readmission rate for non-respiratory complications within 30 days was similar at 10% from 10.5%. And there were slightly less emergency department visits within 48 hours of discharge at 2.5% from 10.5%. I would say that this data suggests that the 4 week map outcomes are comparable to the 6 to 7 week map. And I would also just comment that it suggests that families can safely care for their child at home, their ventilator-dependent child at home. And so what's the significance of this research? I think it highlights the importance of a multidisciplinary team. This map could not have become an entity without all the disciplines involved in the collaboration amongst specialties and just the entire care team. The study also focuses on patient outcomes. I think it's important to identify problems where they are so that we can understand them better and figure out how to fix any problems and move forward to optimize patient outcomes, especially amongst a multidisciplinary collaboration. And the driving force of this H&V program is quality of life, getting families to be reunited with their ventilator-dependent child at home, with their siblings, in their home environment. And so if there's ways that we can reduce mortality rate, reduce readmission rates, and that will certainly optimize quality of life as well. And so where do we go in the future? We're working on an H&V registry to expand our data collection. We'd like to do deeper analysis. Are there certain characteristics that correlate with extended length of stay or readmission rates, such as comorbidities or if the primary language is not English? And we'd like to continue multidisciplinary collaboration because it's been able to bring about this wonderful H&V map, and we look forward to see where the future takes us working together as a team across multiple disciplines. Thank you. And this is the initial H&V map pilot team listed here, and some of them are pictured as well. And these are my references. Thank you so much.